1. Please start. We are live.
So, good evening, everyone. Good evening, faculty and delegates to join the webinar today. So, today we can discuss about GI cancer. So, I would like to invite Dr. Asim Samar, sir. He's a senior consultant medical oncology, Bhagwan Mahavir Center, Research Center, Jaipur. So, it's over to you, sir.
Yeah, thank you, Team Horizon, and thank you, our speakers and the panel members. So we have organized 3 days meeting. So today is the second day, and very focused on the very specific topics. So first we will cover the GI. Yesterday we covered the GU session, in which we have discussed prostate, RCC, and urothelial cancer. Now today we'll discuss the GI system, and the first speaker for this meeting is Dr. Devesh Goyal, our dear friend, and he is consultant in the Fortis Hospital, Jaipur, and his topic will be abstract of LBA 248, a two-arm randomized open-label prospective design superiority phase 3 clinical trial to compare the efficacy of the docetaxel, oxaliplatin, and capecitabine versus 5FU, followed by the docetaxel versus Folfox7 in advanced gastric cancer. This is known as a DOC-GC study. It's a very important and landmark study. So, Dr. Devesh Goyal, over to you.
So, can I share my screen?
Yes, yes, please.
So, thank you, Asim bhai. I think very well. I think show is going on. So I am opener of today's today's session. So I think opening batsman, the limited time only hardly 1 or 2 hours match, hardly 1 or 2 hour for me. So short run. I think the opener is the opening batsman is, I think, run with the shorter time. So definitely we will discuss on this two-arm randomized open label prospective superiority design phase 3 clinical trial to compare the efficacy of docetaxel plus oxaliplatin or 5FU based regime followed by the docetaxel versus capox or amfolfox7 in advanced gastric cancer. So this was trial was done in the Tata Memorial Center. So this study is the LBA 248. So that we all know that chemotherapy is still a backbone in patient with advanced gastroesophageal junction or gastric cancer. So the remaining 5FU plus platinum analog is the backbone of therapy. So addition of docetaxel definitely increased response rate, PFS, and possibly OS, but increased toxicity also. So the appropriate duration of therapy in advanced GE junction has not been ascertained. So the study design is histologically confirmed HER2 negative adenocarcinoma of GE junction or stomach, M1 or T and category M0 but unresectable disease, adequate PS0 to 2 and adequate end organ function. So in this trial 1:1 randomized between two regimes. So in this, the first regime is the mFOLFOX7. So every 2 weeks up to 6 months, compared with this the docetaxel with 5FU plus oxaliplatin every 2 weeks up to a maximum of 4 months, so approximately 8 cycle. And then if stable disease, partial response or complete response is achieved, so docetaxel every 3 weeks will continue till progression or toxicity or patient choice. So in this definitely the dose regime is the docetaxel 50 milligram every 2 weeks. Along with this Folfox regime, the oxaliplatin 130 or 85 milligram per meter square, and 5FU is means 2.4 gram over 46-hour infusion. So this trial in this 455 patient were underwent screening. 160 were assigned to receive this Folfox or Capox, and 163 were assigned to receive DOX or DOF based regime. So as shown that baseline characteristics are very well matched, age are almost 50 years, and the PS2 are almost 16% of patient and the primary tumor location are similar, proximal as well as body of intestinal, and but site of metastasis are higher peritoneum compared to the liver, and treatment regimes are similar. So the in this graph shows that overall survival is the at 12 months overall survival in Folfox arm is the 38 percent compared to the 34.6 in this DOX or DOF arm. So still the graph is curve is overlapping and lastly separate, but it is the OS is not so very well achieved. So as we all know that common grade 3 as well as 4 treatment related adverse event are higher in this DOX or DOF arm, 79 compared to the 51. So almost 53% compared to the 33%. Neutropenia is still higher, 21% in DOX arm, and the diarrhea as well as hand-foot syndrome or CINV are similarly, the toxic effects are higher in this DOX or DOF arm. So other result as well as the exploratory analysis showed no difference in rates, response rate as well as quality of life were observed between two arms, and proportion receiving second line therapies 32.7%. So greater proportion receiving Folfox or Capox received second line treatment compared to patient receiving DOX or DOF. So this shows that in this modified ACRG classification, so most of patients are microsite stable, satellite stable, MSS stable, TP53 mutant, but T53 wild type is 44%, but higher MSI high is only and only 1%. But genetic alteration shows that there is TP53 is more compared than BRCA. So the conclusion of this trial or this abstract, so Folfox or Capox for a duration of 6 months should continue to remain the backbone as well as standard in this HER2 negative gastric as well as GE junction adenocarcinoma. The addition of docetaxel was feasible and may benefit a cohort of patient, but overall didn't improve oncological endpoints or patient related outcomes and was additionally associated with increase in grade 3 or 4 therapy related adverse events. So lesser than expected patient received second line therapy in this trial. So NGS also revealed low MSI rates and higher than expected rate of somatic BRCA alteration. So definitely this trial was conducted in this Tata Cancer supported by the grants from the NAG Foundation as well as the ICOR. So thanks. Thank you, Asim Bhai. So I think in this trial, they showed that Folfox regimes slightly better compared to the if we are adding docetaxel to this regime.
Yes, yes. But Dr. Devesh, would you believe this trial, or what is there in your practice actually?
I think still
Would
we
be
are
treating
using the
like this?
plot is same. I think DOX regimes. So docetaxel with the regime of Folfox versus the Folfox. So I think this trial I couldn't understand.
Yeah,
Still.
because earlier they have clearly shown that adding docetaxel in the 5FU arm gives a clear-cut benefit in terms of the survival, right? So this is there, but still, I guess the toxicity profile was better in the Folfox arm, I guess.
So in my
What do you
practice,
feel?
if just I am choosing this regime, so if the performance is okay, well, young fit patient, so this regime I will choose. Otherwise, I will compatible with this dual regime.
Dual level. Okay, are we hesitate to use docetaxel in such a dose or such a frequency?
I think I am using very less. I think my preference is still Folfox compared to this docetaxel add on this regime.
Yeah, because
But
generally what happens with docetaxel is it causes severe mucositis.
yeah,
And the GI cancer patient already they are compromised nutritionally, and further if mucositis happens and it stays for 5, 6, 7 days, then the patient's nutrition further compromised, and the giving the cycles in the further down the lines, it is very difficult rather than Folpox.
so yeah, definitely if we are using in this advanced metastatic setting or so I think 2 drug regime is slightly tolerable and better I think compared to the 3 drug.
And we have most of the patients supported by the government agencies, so they don't have any code for supportive care. This is the biggest problem for choosing the myelosuppressive regimen.
Yeah, very well said.
Yeah.
Yeah.
Yeah. Okay. Nice presentation,
you.
Dr. Devesh. Thank you very
Thank
much.
you, Asim bhai. Thank you.
Thank you. So I would invite the next speaker, uh, Dr. Rohit Rebello. He is Assistant Professor Medical Oncology in Ananta Institute of Medical Sciences, Udaipur, and he will be speaking on the ESCORT Neo trial. Dr. Rohit is our good friend, and whenever we organize a conference, we first remember him because he is a very good speaker. So, Dr. Rohit, over to you.
Thank you, sir, for those kind
Yesterday, I
words.
was actually intention like when you left the group and all that. So I asked the organizer, please call him in anyhow. You should include him.
No, they had not
Yeah.
sent me the PPT, sir. I was asking for more than a
Yeah,
week.
I know. I know.
Yes, yes. Okay, sir.
Very eager to listen you. Yeah.
Yes, I'll share my screen now. Is my screen visible and am I audible?
Yes, sir.
Okay. Okay. Good evening, everybody. So today's talk is on neoadjuvant chemotherapy in resectable chemoimmunotherapy in resectable esophageal cancer. Now we all know that standard of care in esophageal cancer is neoadjuvant chemoradiation. I think that has been proven by the cross study. The cross study showed almost a 49% pathological complete response rate. And till date, no other study has managed to actually reach that PCR rate as well as the survival benefit that was shown by neoadjuvant chemoradiation followed by surgery. We had two other studies. One was the Keynote 585 as well as the Matterhorn study. The Keynote 585 was with neoadjuvant and adjuvant pembrolizumab, and the Matterhorn study was using FLOT with or without durvalumab in resectable gastric and gastroesophageal junction carcinomas. However, both of these studies actually did not show such significant, like the Keynote study did not show a significant overall survival benefit and thus can be considered a negative study. And the Matterhorn study did show a benefit of pathological complete response rate, but nothing to the levels that you get with the cross regimen. So the treatment of esophageal cancer is basically divided into operable and inoperable esophageal cancers. In operable cancers, the cross regimen is still the standard of care, where you give neoadjuvant chemoradiation with paclitaxel, 41.4 gray, and then take the patient up for surgery within after 4 to 6 weeks. In inoperable patients, generally a radical intent dose is given of 50.4 gray over 5 weeks. And then, of course, there's a role of adjuvant nivolumab in patients who do not achieve pathological complete response. That will be discussed later. So esophageal cancer is the seventh most common cancer globally. It's a novel multimodality treatment approach should be explored to overcome the failure after surgery. So camrelizumab is a PD-1 inhibitor, which in combination with Pacli and Cis has been approved as a standard first-line treatment in China. Previous phase 2 studies have shown that there are high pathological complete response rates. So this study is the first phase 3 study, open label, to compare the efficacy and safety of neoadjuvant camrelizumab plus chemotherapy versus chemotherapy in resectable locally advanced esophageal squamous cell carcinomas. So the different thing about this study is they have actually used an arm with paclitaxel, which is kind of considered to be the standard neoadjuvant regimen other than capox that we generally probably use in esophageal cancers. But here they added an arm of albumin-bound paclitaxel with immunotherapy and pacli-cis with immunotherapy. And then obviously in the immunotherapy arm, there was a maintenance phase of up to 15 cycles. So the dose of nab-pacli given was 125 milligram day 1 and day 8 every 3 weeks, and the standard dose of paclitaxel was used. The co-primary endpoints were PCR and event-free survival, with other secondary endpoints like OS as well as major pathological response rates. So the PCR analysis was to be conducted when all participants have achieved a surgical outcome with pathology obtained and surgery not performed at one-sided alpha of 0.005. So one can see that about 391 patients were taken, which were equally distributed between the three arms. And even if you look at the intent to treat population, about 32% of the patients had PDL1 less than 1%. About 16% of the patients had PDL1 more than 10%. There is a little bit of a bias where more number of patients were PDL1 more than 10% in the immunotherapy arm as compared to the chemotherapy arm. And other than that, by and large, they all look the same. So the primary endpoint, which is pathological complete response rate, the PCR rate in group A, that is with the nab-paclitaxel, was 28%, as compared to the PCR rate of 15.4% in the Pacli with immunotherapy arm, that is a non-nab-pacli arm, and 4.7% in the paclitaxel arm. So what we understand from this particular data is there is definitely a benefit of adding immunotherapy in the neoadjuvant setting, but there is something special about adding nab-pacli. Now, generally, pacli-carbo is the second line treatment that is given even in metastatic cancers, except nab-pacli is considered a standard guideline in the Japanese guidelines, but the normal NCCN guidelines recommend pacli-carbo after capox in the metastatic setting. But here you observe that nab-pacli actually is giving a very significant improvement in PCR rate. Now, this has probable reason for this is the lower use of steroids in nab-paclitaxel, because as we all know, giving paclitaxel is always a dangerous thing, especially when you don't use steroids. So steroids are a part of the pre-medication, and probably this is stunting some of the effect of immunotherapy. So when nab-pacli is used and obviously steroid is not used, you're seeing almost a doubling of the pathological complete response rate. So I think my takeaway from the study is this comparison between nab-pacli as well as pacli also plays a significant role. I'm not that excited that this will become the standard of care, because as we mentioned, even the nab-pacli arm, it gives you only 28% PCR rates, whereas the cross trial has shown 49% PCR rates. Obviously, cross trial comparisons are not right, but I would like to see a study where the neoadjuvant CTRT arm is compared with the immunotherapy arm, and then we would probably finally have an answer. Or probably a subset of patients with very high PD-L1 could be taken just for chemotherapy, and maybe you could avoid the side effects of radiation. So on subgroup analysis, they look by and large the same. There's not any significant difference. And if you look at the major pathological response rates also, they are 59% in the nab-pacli arm, 36% in the pacli arm, and 20% in the TP arm. And even if you look at the regression grades, the nab-pacli arm did significantly better, with better regression as compared to the pacli arm. So the summary of the surgery: most patients underwent the McEwen's surgery with a 2-field lymph node dissection, with very few patients undergoing a 3-field lymph node dissection. Most of the patients, about 95 to 99% of the patients, had actually an R0 resection. And the mortality within 30 days was between 1 to 2%. So if you look at the adverse events, about 46 patients had more than grade 3, or 34% of the patients had more than grade 3 adverse events in the nab-pacli arm, and 31% in the pacli, and 29%, so almost equal amongst all arms. And the serious adverse events also were between 5 to 10%. So immunologically related adverse events were obviously seen in about grade 3, which is the one we are more worried about, was seen in 4.5 and 3.8% of the patients, little more in the nab-pacli arm and little less in the pacli arm. Probably, the fact that we are using steroids might have stunted even the toxicity as well as the response. So the author's conclusion was, this is the first phase 3 study evaluating neoadjuvant immunotherapy plus chemotherapy versus chemotherapy for locally advanced esophageal squamous cell carcinoma. So this drug, the immunotherapy molecule with chemo, significantly improves the PCR rate in intent to treat population. The one very important thing I got from this study is probably nab-pacli is the way to go when immunotherapy is being combined with chemotherapy, because you don't have to use steroids. And definitely we see that we have a phase 3 randomized data showing an improvement in pathological complete response, which basically, and also the major pathological response. So obviously the response rates are better by using nab-pacli, and the Japanese guidelines do recommend nab-pacli as a second line after capox. The study continues to mature for co-primary endpoint of event-free survival. The combined regimen demonstrates acceptable safety profile. So the neoadjuvant immuno plus chemo combination may hold a promise as a potential, but I would not make this the standard of care, because I still think neoadjuvant CTRT followed by surgery is the way to go. We need to remember that this nab-pacli interaction with steroids probably is something that gave a very significantly better response rate as compared to the pacli arm. RT plus immunotherapy would be a little more complex, because if you look at how RT is planned, right, with this recent IMRT and all these advanced techniques, they tend to give a lot of dose to the lung. So when this lot of low dose bath goes to the lung, you always have this problem with the reactions. So because of that, I'm not very confident about that. So that's why I personally, my take in this is that we need to wait for more data and that's currently the standard of care still remains chemoradiation followed by surgery. Thank you, sir.
Thank you, Dr. Roy. Actually, I guess the patient who are not fit for the chemoradiation upfront, then they might go with this regimen.
Yes,
And you
definitely.
rightly said, like nab-paclitaxel gives more pathological CR, because we have seen in the breast cancer patient also in the Jaipar Septo trial, which had shown like albumin-bound paclitaxel is good for creating more pathological CR, right? This is the message, I guess. But yes, in second line regimen, we can give this. Hmm? Yeah, okay. Thank you very much, Rohit.
Thank you, sir.
Thank you. So we'll call the next speaker now. So,
So next is debate, no?
yeah, debate. I will invite that. So, yes, Dr. Ankur. I'm distracted.
Good
Actually.
evening, boss.
So we have debate on day 2. Just a minute. I have a lot of messages now. Okay, so there are some controversies in the neoadjuvant management of esophageal cancer and gastroesophageal junction adenocarcinoma. So we have planned a debate, and debate is NSCT versus NSCTRT in CA esophagus. So Dr. Ankur Punia will speak for in favor of this regimen, and Dr. Kinjal R. Jani will speak against. So Dr. Ankur Punia is our good friend, and he is assistant professor in Department of Medical Oncology in Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. And Dr. Kinjal Jani is MD and Director and Head of the Department of Radiation Oncology Department, SCG Cancer Center, Ahmedabad. So over to you, Dr. Ankur.
Good evening, everybody.
Good evening.
So today, now the topic given me is regarding a debate whether to give neoadjuvant chemotherapy or whether to give neoadjuvant chemoradiotherapy in carcinoma esophagus. For a long, long time now, the radiation has it's sort of a standard chemoradiation, particularly in squamous cell carcinoma, not per se in adenocarcinoma, but for a long time it has been the standard of care since we have the cross protocol. So my job is to go into favor of chemotherapy. Basic, we all know that esophageal cancer with node positive or advanced disease have a very poor outcome, and long-term outcomes are very, very poor with just surgery. That's why a long time back, multiple modalities has been tried, and we don't treat now these patients just with surgery. We give some sort of additional treatment, chemotherapy or chemoradiation most commonly, but we look at the evidence what is emerging now for these patients. So this is the same thing we use why we use neoadjuvant therapies to reduce the tumor bulk, increase the chance of axial resection, treat the micrometastases, improve the dysphagia and the nutritional status of the patient. So eventually he might be able to tolerate the further standard definite therapy better. So can we accept that NSCA-TRT is the standard of care for all patients? One size cannot fit each and everyone. So we are going to look at that. So we are aware with all these trials about the role of neoadjuvant chemotherapy. It started with one of the biggest main trial was MAGIC trial, in which ECF was compared to surgery versus surgery alone. It showed overall survival benefit. And now recently we had the FLOT4 trial. But the thing was, majority of these patients in these studies were adenocarcinoma in the newer trials, and basically were G junction or lower esophageal adenocarcinoma. Older trials still had a good chunk of squamous cell carcinoma. But all of these trials showed that yes, addition of chemotherapy definitely helps to these patients by just doing surgery alone. And there is a good enough survival benefit at 5 years. We can see it varies from 10 to 15%. So yes, patient, helps with chemotherapy, irrespective whether there's squamous or adenocarcinoma. In multiple phase 3 trials have shown the same thing. The same thing has been shown in this, we can really see this Kaplan-Meier curve that survival has improved in all the trials of chemotherapy, or 9 to 15% in overall survival. Then came the study of combining chemo with chemoradiation. So standard of care, which is being used for majority of squamous cell carcinoma, I will say nowadays, is the cross trial in which we give neoadjuvant radiation along with the weekly paclitaxel regimen, and sort of has become the standard of care. We have now 10-year outcome also of this trial, which is continuing to show benefit more so in the squamous subgroup, less so in the adenocarcinoma subgroup. So as I told you, the cross trial had a lot of patients, but very few patients were adenocarcinoma. Majority of that patients were squamous cell carcinoma at that time. So we cannot really say that how much of this regimen is definitely helping this small subgroup just based on this study, though we have started using in a lot of patients. This is just to show that there have been numerous smaller studies of just neoadjuvant RT, and most of these studies failed to show any benefit of just giving neoadjuvant radiation and doing surgery. Plot trial, we are all aware now, sort of become now the standard of care in the adenocarcinoma subgroup. We know that radiation doesn't work that much well in the adenocarcinoma subgroup, so we started using more and more of chemotherapy. And FLOT trial basically defined that what chemotherapy to use, and we know now we use FLOT chemotherapy, neoadjuvant 4 cycles, then surgery, and then adjuvant 4 cycles. So it showed that FLOT chemotherapy regimen is better than ECF or ECX regimen with the improved PCR rate, R0 resection, PFS, and OS. So why now we have not had this meta-analysis also of multiple trials have been done, because earlier we didn't have any head-to-head study, which again the meta-analysis showed that there was no any benefit of adding radiation, and there was no difference in OS or PFS whether we give radiation or just chemotherapy in the neoadjuvant setting for these patients. So now this is a newer data which came of the NEO-AGIS study. NEO-AGIS was basically, it was more for adenocarcinoma patients. They randomized patients to whether to give the cross protocol or to give chemotherapy, surgery, followed by chemotherapy, just like FLOT trial. Though this trial was started earlier, majority of the patients received ECF in this study, and only around 10% of patients hardly received FLOT chemotherapy in this regimen. Still, it showed that both the arms were equal, whether to use chemotherapy or whether you give cross protocol, survivals were completely same. There was no difference in overall survival, though pathological response rates were improved in the RT arm, but it didn't impacted the overall survival. So this trial clearly showed that there was no addition benefit of adding, radiation to chemotherapy, a little bit older chemotherapy, which is now gone out of fashion, ECF, ECX. And it is more or less same whether to give chemotherapy or to give the radiation chemo cross protocol for adenocarcinoma patients per se or G-junction tumors. So we know that FLOT is better than ECF, but cross is not better than ECF. So indirectly, we can say that FLOT might be better than ECF. The trials are going on, which will tell us more. But at least still tells us that we can give either of the regimen and we don't have to go for radiation for each and every patient. So we're looking at a toxicity point of view. When we give chemo radiation, we have to look out for more late-term complications, and there are slightly increased surgical morbidity in many studies as well, up to 10% in the POET study. Perioperative chemotherapy, yes, it has also its caveats. There is more of acute toxicity. Hematological toxicities are more common, neutropenia and everything has increased. But surgical mortality is not that much increased with just giving chemotherapy. And it's simple to start and give, and it can be used in a broad case number of cases. So yes, if you're afraid to give FLOT, we have data to give. We don't have the data, but we can indirectly compare and try FOLFOX or FLO, but we will have more data with the newer trials in the next 2 or 3 years will clearly tell us what chemotherapy is helpful for these patients and when you don't need to give radiation at all. So this is the JCOG 1109 study. This was presented in ASCO 21. It was a different study. It was basically for squamous cell carcinoma, esophageal cancer patients. And they randomized to 3 arms. They gave neoadjuvant chemotherapy cisplatin 5-FU, neoadjuvant DCF 3 cycles, or neoadjuvant chemoradiation. They use a slightly different backbone, which is the sort of a standard in the Japanese population. Their standard is to give 5-FU cisplatin and not the cross protocol. So this was the neoadjuvant treatment, followed by which surgery was done, a D2 surgery. You can see baseline characteristics are well matched. Almost all the patients are squamous cell carcinoma in this study. So we look at the overall survival. If we compare patient who received just CF versus DCF, OS was improved. It was 72 versus 62%, 10% difference. When then we compare patient who received neoadjuvant just chemotherapy versus neoadjuvant chemo RT, we can see that it was slightly better in the chemo RT arm, but it was not statistically significant. Overall, we compare the overall survival in all these three arms. You can see that it was 72-68 versus 62%, but it was not statistically significant in either the arms, though the OS was increased and the maximum in the DCF arm. So if we do a cross comparison, different trials, we can see in the JCOG, we just Neo DCF was given. 3-year OS was 72%. We compared with cross arm, it was 51%. And this Neo CRTC arm, this was basically a Chinese counterpart of cross study. And it again showed a 65%. PAT CR, yes, was increased with chemo radiation, but it didn't, turn into a better overall survival difference. This study, JCOG, had a PAT CR was around 40% in the RT arm, whether it was just around 20% in the DCF arm, but still the overall survival was not different, and it was slightly better in the chemotherapy arm. Chemotherapy toxicities, as I already told you, hematological toxicities were definitely higher when we give DCF. Neutropenia, febrile neutropenia, all were more when we give neoadjuvant DCF chemotherapy. So this is one of the different study in which basically patient with deficient or MSI deficient MMR were taken. Resectable, esophageal gastric cancer patients were taken. And we can see the responses to just immunotherapy in this subgroup. There was 60% PAT CR, majority of patient has a major pathological response. So avoiding chemotherapy and radiation altogether showed a very good response rate, which was not seen even with just chemotherapy or chemo RT in all the arms. So this is not a big subgroup. Yes, for this particular subgroup of MSI-high or deficient MMR patients, we can avoid altogether chemotherapy and radiation and just get away with giving immunotherapy. So we have these multiple trials ongoing. Top Gear trial, this is basically the same thing in adenocarcinoma, which they are comparing chemotherapy versus chemo-RT. Again, the Critics 2 is going on. Critics 1 showed that in the adenocarcinoma patients, chemotherapy is equivalent to cross regimen. So again, in Critics 2, they are slightly redefining that and doing the similar race studies going on, which will basically comparing FLOT versus the chemo-RT. So these trials are going on, which will further solidify whether there is any role of radiation now per se to give in the neoadjuvant setting. So looking at the ESMO guidelines, yes, they show that squamous cell carcinoma neoadjuvant CRT is the standard arm, is the standard of care which has to be used. But in adenocarcinoma, standard grade 1 recommendation is to adjuvant for neoadjuvant FLOT, but also you can use neoadjuvant CRT. But I think we are moving now more towards chemotherapy in the adenocarcinoma, and we are now developing more and more evidence of using chemotherapy in the squamous cell carcinoma as well, this Japanese study. So we have to understand that one size does not fit all. Yes, it depends on a multiple factors whether to give chemo radiation or just chemotherapy, because it also depends on what kind of surgery you are going to do, what kind of surgical help you will get. Because in if you look at the Japanese study, they have a very extensive resections. The median lymph node yield was around 30-40. So you need a very extensive resection to get away just with the chemotherapy. It has been shown in multiple retrospective analysis of previous trials as well. Patients who underwent extensive resections might get away with radiation, and patient who doesn't have that much extensive resection and not that much of a lymph node yield, radiation might help in those patients. Thank you. You are mute, Dr. Asim.
Okay. Okay, thank you, Dr. Ankur. And now it's your turn, Dr. Dr. Kinjal Jani. So I would expect your defense.
Yes, good evening all. Thank you, Dr. Asim, for inviting me for this debate. I'll start screening. I'll just do the screen sharing. Is it visible now?
Yes, sir,
Yes,
it's
yes.
visible.
So, I have seen a lot of change in practice in last 20 years. When I started in early 2000s, esophagus, the disease of esophagus coming, majority of the patients were palliative. We were not even thinking about curative treatment for them, majority of them. And as we have seen a lot of changes, a lot of different kinds of treatments have happened. And if you see, the incidence is also increasing all across the world. Earlier, it was like esophagus and stomach were more common disease for Japanese or Chinese people, but now we do see an increase in across the world where the cases are increasing. Surgery, though, if you talk about a curative treatment, surgery remains the mainstay. But there are definitely so many trials, adding different treatment to surgery to have a better benefit. Why do we need neoadjuvant treatment? That is the important thing. We need more R0 resections. We want good loco-regional as well as distant disease control, and eventually we want to improve the survival. At the same time, it should be tolerable treatment when whatever you are giving, because that eventually the patient has to go for a surgery. So they should be very well tolerated. That is very important. And just if you see the guidelines at this point of time, if you talk about NCCN for a squamous cell carcinoma, very early lesion, you can do a surgery, or for anything else, you go for a preoperative chemoradiation or you go for a definitive chemoradiation. That is the main guideline what it suggests in 2024. And for adenocarcinomas, again, a very early lesion, you go for a surgery straight away, or any other disease, any advanced tumor, you go for a preferred option. Category 1 is a preoperative chemoradiation followed by surgery. Or we can, as rightly mentioned by my colleague, Dr. Ankur, that we can go for a perioperative chemotherapy followed by surgery. A role of immunotherapy is coming up in a big way in a neoadjuvant setting. It was very nice to listen to Dr. Rohit and the first talk also. So a lot of immunotherapy is coming up in big way. We are adding nivolumab if there is no pathological CR after the cross regimen. So the debate comes in this area, in the proximal G junction tumors. Specifically Sievert type 1 and 2. They behave like an esophageal cancer, both in the terms of a nodal pattern spread or terms of survival. And the Sievert 3 usually, behaves like a stomach tumor. So you have to be very careful in selecting the treatment for that particular patient. And nowadays we do like almost all the sites, we do MDT discussion before we plan for treatment. So the important discussion would be from the surgeon that, what kind of treatment he wants, how fit the patient is nutritionally, how is the condition of that patient, whether the patient will be able to tolerate only the chemotherapy, what about chemoradiotherapy. So all sit together and we decide. But generally for a G junction tumor type 1, type 2, we treat them like esophagus, and type 3 usually we treat like gastric tumors. Now data on CTRT, there is a lot of data, a lot of studies I have put, I'm thankful to my colleague, Dr. Samir, who has made this presentation. He is a senior consultant working with me. He has put in so many trials. I'm not going to read all the trials, but it all started with RTOG 8501, where they started that if you give 50.4 gray of radiation along with cisplatin plus 5FU, there is an advantage. There is an advantage of adding chemoradiation before surgery. And there was a bit of improvement in the adenocarcinoma also, and long-term survival benefit as well. So different trials. You can see here the different phase 3 preoperative chemoradiation trials in esophagus and G junction tumors. They all have showed that they had a good amount of adenocarcinoma also. The R0 resection was quite good. Pathological complete response was also in the range of 20 to 40. If you see the overall survival, as rightly mentioned by my colleague, that overall survival, all the trials are not showing too much of difference whether you go for neoadjuvant chemoradiation versus the neoadjuvant chemotherapy. So you have to choose your patients accordingly. And the results of phase 3 preoperative or perioperative chemotherapy trials in esophagus and G junction tumors. So again, these are different trials where you can give perioperative ECX, perioperative CT in the form of 5FU cisplatin followed by surgery. Here also, if you see the R0 dissection rates are comparatively lesser compared to the chemoradiation arm, and pathological complete response is also quite inferior compared to neoadjuvant chemoradiation arm. Now, impact of pathological complete response following neoadjuvant chemoradiotherapy in esophageal cancer. So you see the conclusion. I'll not go into the details about it. The complete pathological response predicts significantly higher rates of overall survival and disease survival in patients with locally advanced esophageal cancers treated with neoadjuvant chemoradiotherapy followed by surgery. And they were all statistically significant, but I am not going to talk in detail about all the studies. Now, this is a meta-analysis, systemic review and meta-analysis of the influence of circumferential resection margin involvement on survival of the patient of operable esophageal cancers. So how does this help? If you see, the CRM involvement is an important predictive factor of poor prognosis. So a patient where you can achieve a R0 resection, they tend to do better than a R1 resection. So you can see here if the CRM is more than 1 millimeter, the survival is better. In all these meta-analysis trials, all the trials are showing that you should have a good CRM. Now came this, everybody discuss about cross trial because this has changed the practice, and we all know, so no need to go into the details of cross trial. But yeah, this is the base, on which everybody discusses that neoadjuvant chemoradiotherapy has become the standard of care. And as you can see in this graph, only surgery is definitely inferior in the adenocarcinoma arm or the squamous cell arm, whereas adding neoadjuvant chemoradiotherapy is definitely better for both squamous as well as adenocarcinoma, but more better for a squamous cell carcinoma, both in the terms of overall survival and progression-free survival. Now this is again a debate of cross versus FLOT for G-junction tumors, where you can use ECF, ECX, or a FLOT. These are a bit toxic drugs, and again, when you talk about the toxicities, tolerating FLOT for Indian patients is sometimes a dicey thing. We always see the literature of Japanese people or Chinese people, or for that matter, American people. So when we talk about our patient, we need to be careful about that. R0 resection definitely is better with the CTRT arm, and PCR is also better for CTRT arm. Now, this study neoadjuvant chemotherapy or chemoradiotherapy for patients with advanced adenocarcinoma of the esophagus. Now, if you talk about only adenocarcinoma also, we can see like when you do it like a cross protocol, PCR is higher even for adenocarcinoma compared to the FLOT. So 23 compared to 12. Again, the number was less, but you can see both are comparable arms. And they compared the FLOT chemotherapy, neoadjuvant chemoradiotherapy, with the cross protocol in locally advanced adenocarcinoma. G-junction tumors 1 and 2 resulted in a better response to the primary tumor, less lymph node metastasis, but without superior survival. So overall survival was equal with FLOT or cross. So that is what this study was showing. They had all T3 and NX adenocarcinomas. POET trial. Now this is a phase 3 trial designed to compare pre-operative chemotherapy and chemoradiotherapy versus chemotherapy alone followed by surgery. So here you give chemotherapy followed by chemoradiation followed by surgery. And this is something we have been doing in early 2000s also, where the surgery was very difficult because of a locally advanced tumor. You give some amount of neoadjuvant chemotherapy, downstage the tumor, then give the benefit of chemoradiation, and then you operate the patient. So again, this trial is also like that. So one arm is having a neoadjuvant chemo followed by CTRT, followed by surgery, and the second arm was neoadjuvant chemotherapy followed by surgery. So the results were the PCR rate 16% versus 2%, p-value of 0.03, and lymph node negative status 64% versus 37, p-value of 0.1, were significantly higher in the chemoradiotherapy arm. Resection rates increased from 79 to 88% when chemoradiation was added to the neoadjuvant chemotherapy. Overall survival showed a trend in favor of preoperative chemoradiotherapy in this study, suggesting that chemoradiotherapy may be superior to chemotherapy alone. Survival after neoadjuvant chemotherapy or chemoradiotherapy for a resectable carcinoma esophagus. This is again an updated meta-analysis. Lot of studies were taken. Adenocarcinomas, majority were adenocarcinomas, and you can see chemoradiotherapy was more favorable. Again, may not be statistically too much significant, but all were showing favor towards the chemoradiotherapy and not the only chemotherapy arm. Maybe immunotherapy might change the picture because we might not even require chemotherapy for some patients and not even radiotherapy. So that might change the future. But right now, as of now, the standard treatment of care is neoadjuvant CTRT. Again, carefully selecting. This is again a meta-analysis. Lot of studies, and all favoring the chemoradiotherapy arm. Again, this is again a big meta-analysis. I'll not go into detail. The 10-year outcome of cross trial has come, and it has showed that the overall survival benefit of patient with these patients are still persisting at 10 years also. So that is something new which has come up. New is going to be a trial, where cross versus perioperative chemotherapy, modified magic or FLOT protocol. Cross again showing better R0 resection, more N0 nodes, a bit better compared to chemo arm. But conclusion was there that it does not change into the overall survival. So when I told earlier also, when we talk about American patients and Indian patients, we see a lot of patients like this. They are lean and thin. You need to be very careful while choosing the treatment for such patients. And right now, a lot of trials are going on. So we'll probably have the answer soon. A lot of trials are having a head-to-head comparison. So these many trials are there. Top Gear, Power and Jar, Next, Critics 2, Protect, React, New Ages, ISOPAC. So all this estimated completion is 2020, 21, 22, 23, 23, 24, 24. So we'll be seeing all these results in coming time, where we might have a different kind of approach for when we are treating our patients. Now, this again showed by my colleagues, so I'll not go into that. So to summarize, both neoadjuvant chemoradiation and perioperative chemotherapy have the definite benefit when compared to surgery alone. When compared both the treatment modalities, NSCTRT scores over better resection rates, fewer loco-regional recurrences, better compliance, and more pathological CR when compared to perioperative chemotherapy, but doesn't show survival benefit over perioperative chemotherapy. Several ongoing studies will eventually give us an answer. But the only thing which we are worried about after the radiotherapy with the old data was complications to lung and heart. Nowadays, as we do a lot of targeted treatment, the complication rates have significantly gone down after the era of IMRT. So we are not too much worried. The only thing is, the mucositis. When you add chemoradiation together, mucositis are more. So I think 5-FU cisplatin, we have moved towards paclicarbo, which is a bit better tolerated drug compared to 5-FU, so that the esophagitis have gone down with that. Okay, with this, I would just thank again for inviting me for this talk. Thank you.
Thank you, Dr. Kinjan. Dr. Ankur, are you there? Okay. Anything for rebuttal, Dr. Ankur?
So yeah, I agree that yes, radiation has been the standard of care, but now we are getting more and more evidence that at least it is equivalent to chemotherapy, is equivalent to chemoradiation. Yes, we have to select the patients. Not every patient can tolerate a single kind of treatment. A patient fit for chemoradiation is, I think, can be considered fit for chemotherapy as well. But what I feel makes a difference is this, what kind of surgery we get. That makes, I think, the biggest difference. If we get the best surgery, then yes, we might get away with chemotherapy. But we don't have enough, if not a high volume center, then maybe chemo-RT might be a better option rather than just giving chemo.
And Dr. Ankur, what about the post-op immunotherapy, which is being tested in the various trials? So it might change the scene.
Immunotherapy, now we have 3 failed studies in gastroesophageal junction. Basically, adenocarcinoma, nivolumab, pembrolizumab, durvalumab, all have failed. All of them showed that PET-CR was increased with the addition of immuno to chemotherapy, but all the failed to show even a DFS benefit. So in esophageal cancer, as clearly as I've shown also in the trial, that PCR basically doesn't make any difference for esophageal cancer, or I'll say esophageal or G junction cancers. PCR doesn't make a difference for overall survival. So maybe that immunotherapy won't come in the early setting per se. Maybe in the adjuvant or patient who doesn't take a PET-CR in all kind of settings, it might come, but not in the perioperative setting.
So, Dr. Kinjal, what is your view about post-treatment stricture in the esophageal area?
So if you're going for when you're going for a preoperative dose, which is like 41.4 gray, and anyways you're going to remove
41 or 45?
41.4, 41.4,
Okay.
45 gray, that is a standard. And for a radical approach, we go up to 50.4. So
Okay.
if you go for a radical RTCT, you are worried about the stricture. And that too, when earlier, I have given 60 gray, 66 gray also. Earlier we used to give. So in that kind of era, there were a lot of strictures happening. But now when you stop it at 50.4, I don't see too much of strictures happening. Yeah.
But surgeon, most of the surgeons don't want to actually operate after the
That
radiation.
depends on the expertise of the surgeons, because I have discussed with a lot of surgeons and on a national forum also, they are very comfortable in operating within 4 to 12 weeks, like not exactly 4 to 6 also, up to 12 weeks they are comfortable, either in rectum or in esophagus. They say they get a good margins. They get a good margins when they're operating. So the feeling was that, after radiotherapy, the surgeons might find it difficult to operate. I'm not seeing that much, with the qualified surgeons and with the robotic surgeries, you don't land up with a lot of complications. So
The surgeons usually seems happy in MDT if we say like patient is going for only NACT and followed by perioperative chemotherapy. And as soon as you say like RT is not in the question, then they feel very happy.
So my center is a heavy center. We treat a lot of private patients also. So we do get a lot of healthy people also of esophagus. And at our place, the standard of care is CTRT at this point of time. Yes, it is changing for the G junction tumors. In stomach, definitely. Stomach, there is a role of neoadjuvant radiation also, but we don't do it. It is purely a chemo for G junction tumors, adenocarcinomas, or stomach tumors. But for esophagus, yeah, we are still comfortable with CTIT. Majority, I mean.
But your surgeon are comfortable in doing surgery for the little bit above the G junction tumor with the robotic surgery?
Yes.
Okay.
My surgeon who works with me, his name is Dr. Devendra Parikh. He
Okay.
works as a doctor to all across India. So half of the days he's moving around for robotic surgery.
Train others, huh?
Train others. So he has a vast experience. And the other doctor which we have is Dr. Jagdish Kothari. He's one of the first MCH oncosurgeon of Ahmedabad. So very senior guy. So we have two good GI surgeons. So they are very comfortable, after operating after chemo radiation.
Yeah, Dr. Jagdish Kothari has come in BMCon also. We listened to him, and actually his lecture was became milestone in that conference, and it was he was very convincing for robotic surgery in various tumors, like in the mediastinal tumors also, the stomach and colorectal tumors. So yes, it is there. So robotic surgery might change the approach of surgeons.
Exactly.
So thank you, Dr. Kinjal, and thank you, Dr. Ankur Punia. So we
I just inform you, Dr. Ankit. So Dr. B.S. Ankit Nehra sir is not joined.
Okay,
No
so
problem.
yeah, so just let me know if he joins in between. We can we'll include him in our discussion.
Sir, he is not joining.
Oh, okay, no problem. Okay, so I'll invite my panelist. First, the senior most, I think, Lalit sir. He does not need any introduction. Lalit Sharma sir, he's a senior consultant medical oncologist at Manipal Hospital, Jaipur. He does not need any introduction. So, are you there, Lalit sir?
Yeah, I'm there.
Hi, sir. Good evening.
Good evening.
Next, we have Dr. Preeti Agarwal. She is a consultant medical oncologist working at Narayana Multi-Specialty Hospital at Jaipur. Welcome, Dr. Preeti.
Thank you.
We have Dr. Manoj Mahajan. Welcome back, sir. Manoj, sir, you're there?
Yes, I'm there.
Hi,
Am I
welcome
audible?
back. Yes, absolutely, sir.
Yes,
So,
sure.
Dr. Manoj Mahajan is, I'll introduce him again. He's a director of oncology services at Pacific Hospital. He's very good friend, very dear friend, and a fantastic clinician. We also have with us Dr. Karan Kumar. He is a DM hepatologist. Dr. Karan, are you there with us?
Yeah, I'm here.
Hi, nice to meet you again. Hi, how are you? Okay, so Dr. Karan is an assistant professor working as working in the hepatology department at Mahatma Gandhi, Jaipur. Okay, so without wasting much time, we'll kick off our session. We will be very crisp and we'll take on the questions as a discussion part. So,
Sir, make it full screen, please.
yes. Is it fine?
Yes, sir, it's moving.
Okay. So, what are we going to discuss in the next 15 to 20 minutes is a very important topic that has haunted probably medical oncology since a very long time. Recently, after the introduction of the combination of atezolizumab and bevacizumab, we had a bit sigh of relief. It is probably going to be, we have routinely been started using these combination now after the approval. And what is hepatocellular carcinoma? We all know it requires a multidisciplinary tumor board discussion and a collaboration among various consultants of different expertise, like medical oncologists, radiation oncologists. We should include the hepatologist. That is, I think, of prime importance nowadays. And the surgeon, hepatic surgeon. Then we have interventional radiologists who should be included in the multidisciplinary tumor board to decide on what is the best treatment for the patient, because we have number of treatment modalities available for our patients now. Especially if the patient has a localized disease that is localized to the liver and does not have a invasion in the macrovascular system. So starting with our case, it's a 62-year-old male. Just a hypothetical case. We have a 62-year-old male who has multiple comorbidities: hypertension, diabetes, hypercholesterolemia, coronary artery disease. He has NASH-related liver cirrhosis since past 5 years, and he has been diagnosed as HCC. And so the exact CT scan I'll let you know the details of the CT scan. So just an introductory part. Lalit sir, can we start with you, please?
Yeah, sure, please.
Sir, in your clinical practice, how frequently do you see metastatic HCC in your clinical practice? How frequently do you see resectable versus unresectable? Because we as medical oncologists, I think it's a huge difference what we are routinely seeing in our clinical practice as compared to a hepatologist who see liver cirrhosis or liver malignancies.
So though we haven't compiled or we haven't kind of published the data, so it will be difficult to come to an exact proportion. But unfortunately, there are a large number of patients who turn out to be unresectable, multifocal, involving multiple segments. And if just to have a rough idea, I would say around say 60 to 70% patients landing up in our OPDs of medical oncology. Probably there is a reference bias also that the earlier lesions probably land up with the IR and hepatologist more. But in our OPD, I would say easily 60 to 70% would be unresectable setting.
Yeah, I think we'll all agree with that. Dr. Karan, in your clinical practice, how do you differ with our clinical practice?
So for actually, we see cirrhotic patients, we will do screening for them with AFP and regular ultrasound monitoring. So for cirrhotic patient, we do really pick up them at early stage. If I will say, if I am seeing 5 to 6 HCC a month, out of them, 2 or 3 will be referred one. Those will be with metastasis or portal vein thrombosis. Remaining still are in the early or the intermediate stage, to which whom we can offer either ablation or maybe transplant also.
Yeah, I think that means around 50% of your cases are relatively earlier stages. Yeah, but I think Dr. Preeti, Dr. Manoj sir, any different opinion?
Yeah, probably that is true. He is like following the whole disease course rather than
Exactly.
end result of the cirrhosis that we see. And he rightly pointed out, the referred patients are most of the time unresectable and advanced, and we have most of the patients are referred only. So the spectrum matches, but he has unreferred patient, his patient, cirrhotic patient, to whom he is following up for long term. Then there is very likely chances that picking up it quite early stage.
Absolutely, I think Dr. Preeti.
Same, yes.
I
We do
think
see
we are not involved
major
in
chunk of unresectable and metastatic disease.
unresectable and metastatic or resectable.
Unresectable.
Yeah. I think that is the big difference in our clinical practice. So most of our patients are, it's very easy for us to decide on treatment because most of the patients have extrahepatic spread. They have either Child-Pugh B or C category. Child-Pugh A is also, I think it's very, in my clinical practice, I don't very often see Child-Pugh A disease. What about you? Dr. Lalit, Dr. Preeti, Dr. Manoj? Child-Pugh A, CPA category.
Again, rare occurrence, but few patients. I have one of the patients who is like Child-Pugh since and almost 3 years of his liver is studied with the SCC, and he's almost 3 years down the line, and he's still we are still continuing with the Tecentriq and Bev combination.
Oh,
so
okay.
It's a rare occurrence like that, but more not very frequent, but it's a rare occurrence.
Right. Okay. So I'll just summarize the case again and just give you the introductory part, what all investigations were done with this case. So he had 2 lesions in the CT scan in the liver. Triphasic CT scan was done. One lesion was in the segment 5 or 5 centimeter. The other was segment 8, 2 centimeter lesion. Serum alpha fetoprotein 1054. No hepatitis, triple H was negative. Child-Pugh scoring B7, Barcelona Clinic liver cancer staging B. So any other investigation you want to look for before you start on treatment? Any other thing? So let us start with Dr. Karan. How would you want to go about this patient? Any other investigation you want to do? Or yeah, so he's a 62-year-old male.
Needs assessment for portal hypertension first. He need an endoscopy for variceal screen to assess the portal hypertension. Secondly, he has number of comorbidities. So definitely we need to assess his performance status. What is his performance status like? He's
PS1.
diabetic, he's
PS1. PS1.
PS1.
Okay. PS1.
PS1. Okay, so
Yeah.
performance status and varicose screening, that is all required to
Okay.
manage this patient further.
Right. So suppose there are two scenarios. The patient has varicose varicose ligation is required. Patient has varicose varices is there. There is one more patient who does not have varices. Similar situation. How do you manage these two patients? How do you want to manage? So basically, the thing is, we know this is a disease which is localized to the liver. We have done the investigations. It's a localized disease. PS1, no varicose bleed versus a varicose varices are there. How do you manage these two patients? What are your guidelines? What does that suggest?
So for early or intermediate stage, the presence of portal hypertension dictates how much liver we can remove. In this patient, suppose he doesn't have any varices, indicates means he's a compensated patient with no portal hypertension. And if the disease is localized to segment 8, means it's a right lobe disease located on the periphery, he can very well be offered a surgical dissection also.
Absolutely.
If the medical conditions are under control. But suppose this patient had portal hypertension also, he had got varices, then he becomes a candidate for transplant rather than going for a surgical dissection. So presence of portal hypertension help us to decide whether we can offer surgical resection alone or patient needs to go for transplant. So
So
thing is for
if as per our understanding, what we generally look at is if a patient is to be considered for transplant, he has to follow all the criteria, that is the Milan criteria.
yes.
Right. So as per this, he is not under that criteria.
Actually, now the criteria universally accepted are UCSF criteria.
UCSF,
They have
yes.
expanded criteria.
Right.
In that, you can take a patient with largest lesion up to 6.5 centimeter, 3 lesions with none of them, the largest among them, 3 lesions are there, and the largest is 4.5 centimeter, and some of the lesion is less than 7.5 centimeter. You can accept them. So he fall under UCSF criteria, which is now accepted guideline to take the patient upfront for transplant.
Okay.
So
Okay.
ideally, he falls within the criteria for transplant.
Okay.
This
Okay.
patient.
Accepted. Fine. And what about local regional therapies? How do you plan local regional therapies for these type of patients? Like
So just to add, for this patient, only thing which will stop transplant in this patient is his comorbidities. Suppose he is having a triple vessel disease, uncontrolled diabetes, then he will be excluded from any major surgery. So that will exclude him from transplant. Second is this AFP. For transplant, there is an arbitrary cutoff of 400. Those patients who are having AFP less than 400, they are less likely to recur after transplant versus those patients who are having AFP more than 400. Since this patient had a AFP of 1054, instead of offering him transplant upfront, I will offer him TACE, wait for that downstage the tumor, wait for AFP velocity, at what rate AFP is rising. Suppose after this TACE, the tumor is getting reduced and AFP is remaining has reduced and this maintaining at a low level, then I will offer him transplant after 3 months.
I think that is what
But
I was
target-
looking for, downstage therapy. So if a patient is not a candidate for transplant, if you want to go for transplant in near future, the treatment that you decide on is basically the downstage therapy, that is the local regional therapy. So we have discussed this. Anybody would like to go for systemic therapy in this patient? Dr. Preeti, can I have your word, please, on this? Localized disease, 2 lesions in the liver, localized to the right half of the liver, segment 5, segment 8, stage.
I think local regional therapy would be better for this patient at this stage.
Okay.
Although there is no head-on-head data comparing local regional versus systemic, and there is data emerging that systemic therapy, giving it very late may not be very helpful to the patient, but presently, yes, local regional therapy.
Dr. Manoj sir, any take on that?
Yes, I think local regional therapy should be.
Dr. Lalit,
Yeah.
I think we are on the same.
I would agree that the first kind of attempt should be to go for any surgical intervention or local regional therapy if feasible. In case that is not feasible, or in case the team kind of considers that I don't know whether I can use the word neoadjuvant kind of therapy, which could kind of shrink the disease, might make it convertible or more feasible for regional therapies, maybe in that scenario, but only I don't know. That is the only two scenarios where I would consider if not amenable to loco-regional therapies, or wherein if the IR team considers it could be helpful putting the patient on systemic therapy and then go for loco-regional.
Regarding the combination, there is an ongoing trial by this STRIDE protocol, Tremeli and Durva, along with TACE Emerald 3. That is a multi-centric global trial going on. Till the results are out, I don't think there is any guideline or recommendation for combination, upfront combination of systemic therapy and local regional therapy for a late stage HCC.
Okay.
Okay, I'm sorry, I had some internet connectivity issue. Okay, so I think we all agree that local regional therapy is the best. Currently, for him, local regional therapy is the best modality that we should offer to him. So basically, what happened? He was offered TACE. I'll just share my slides. Just give me 1 minute. He was offered TACE that was done twice at a gap of 3 months. And after the TACE was done, after the second TACE, am I audible?
Yes, yes.
Yes, sir, you
Okay.
are. Your
Yeah,
voice is
okay, I'm
audible.
so sorry. Okay, so he was offered TACE. Let me continue the case. The slides are visible, right?
Not, sir.
No.
Not yet. 1 second. Just give me 1 second, please. Are they visible now?
Yeah,
Yes, sir.
They're not moving.
Tech support, can you please help now?
Just 1 second. Yes. Can anyone share my slides for you? Or like, I am not able to. I don't know some days.
Sir, kindly share your PPT slide.
Should I stop sharing or?
Sir, your PPT slide is not visible.
1 second. 1 second. Is it visible now?
Yes, sir.
Okay.
It's moving.
So, okay. Okay. So this patient was offered TACE twice at a gap of 3 months. The lesion, 5 centimeter lesion reduced to 2.8 centimeter. The 2 centimeter lesion remains unchanged. His AFP level reduced to 500. No varicose, no esophageal varices, no ascites, no encephalopathy. Child took A6 liver function. Now, what do you want to do now? He is A6. Not no esophageal varices, no
MSc
ascites,
transplant.
multiple comorbidities. Exactly. Exactly. So basically, the bridging therapy has helped him. He should be going for a transplant, but logistic issues, transplant is not possible. Ideally, the treatment for this guy is transplant. But logistic issues, no transplant possible for whatever reason. What is the next option for us? Dr. Manoj, Dr. Preeti?
So the next option remains systemic therapy. Yes, if the transplant is not feasible, maybe because of comorbidities, maybe because of logistics. The next option is systemic therapy, and systemic therapy, the first line remains atezo plus bev, immunotherapy plus bev.
Okay, there are a few things that we missed in between. It's okay. We'll discuss our systemic therapy first. Okay, so are we all on the same track? We want to use systemic therapy, atezo plus bev for this patient?
We need to be
Dr.
extremely
Manoj, Dr.
careful.
Lalit?
Yeah.
Clarity for clarity
Yes.
sake.
We need.
How we,
Yeah.
Sorry?
we need to be extremely careful in terms of like, because the transplant is not feasible. So because of the comorbidities, and especially with the BAVE, we have a lot of like hypertension is one of the really worrisome, and that if patient is diabetic, hypertensive, cardiac comorbidities. So all these may be precipitated in long run. And so usually in such a situation, I go for reduced dose of avastin as per the as not as in the recommendations, and we can continue with the tercentric. And with
Okay, so
if let's say patients comorbidities are very well controlled, and even with the low dose BEV is tolerating well, then I would vouch for optimizing the dose in subsequent therapies.
okay, so the dose that you start with is 10 mg per kg or even lower than that?
Uh, Again, the extent of the control in the comorbidities. If it is like
Okay, okay,
borderline,
okay.
then based on that, I'll start from the half of the dose, and then we'll up titrate to the near 100%.
I think that is the clinician-based decision. I think I completely agree with that. It's a clinician-based decision, depending on the performance status and what are the comorbidities status, whether they are well controlled or not. We should take a call about what treatment, what dose should we give. Dr. Lalit,
Yeah, I
any take
would,
on?
I would totally agree with Dr. Mahajan's take that in case the comorbidities are well controlled, we can go ahead with all recommended full doses. But in case there are some concerns, we might start with lower doses depending on case to case basis. But having said that, I would also like to convey the patient that isn't any very concrete data for me to choose between atezolizumab Bev versus lenvatinib. I agree that versus sorafenib we have a decent data, but there is data compiling that the magnitude of advantage versus lenvatinib and maybe down the line with cabozantinib might not be that stark as is with sorafenib.
So coming, it's a very important point that you brought out. Coming to that, does the etiology define what treatment you should provide to the patient? There are two patients, for example, let me be very clear. There are two patients. There is one patient who has viral hepatitis and that has caused hepatocellular carcinoma. There is one more patient who has non-alcoholic steatohepatitis related hepatocellular carcinoma. So does that click anything whether you want to give a specific form of treatment for this type of patient? A patient of hepatocellular carcinoma needs systemic therapy. The etiology, there are two patients, etiologies are different. Dr. Manoj, Dr. Preeti, Dr. Lalit, Dr. Karan will have your take on this.
Yes.
So is there any data that is suggesting that yes, you should look at the etiology also as of now? Currently, today's practice, do you want to look at the etiology to say that yes, in this patient, I would like to use lenvatinib. This is the patient I would like to use atezo and bev. Dr. Manoj, am I audible? Dr. Manoj, Dr. Lalit?
Yeah, hi. You are audible, but reason for my silence is I'm not aware of it.
Okay. Oh, I'm so sorry. Okay.
Then
So
I can take that
anyone?
question.
So
Yes,
yes,
I can.
there is some subset
Yes.
analysis where
Okay.
the patients with viral hepatitis associated, viral cirrhosis associated HCC, the immunotherapy response rates are better compared to those patients who have NASH associated liver cirrhosis. So in those subset patients, you may use lenvatinib in NASH associated and viral. There is some propensity towards using immunotherapy. Yeah, there is subset data, but there is no head-on-head trial.
Yeah. Dr. Karan, your take on that? We'll
Yes.
come to the details of the
So
trials.
first of all, I would like to highlight the NASH as a cause of cirrhosis is now leading at a very rapid rate. Earlier,
Absolutely.
HCC was this Hep C related cirrhosis was the main cause of HCC. Now, the latest study published by the hepatology societies have shown that NASH-related cirrhosis is as high as around 55 to 60%. So almost more than half of the patient now are having NASH-related cirrhosis, which will ultimately transform into HCC. This is the first thing, NASH-related cirrhosis is on the highlight. Second, in the
Okay.
IMBRAVE also, there is post-hoc analysis of the IMBRAVE trial and multiple real-world studies in which they have compared the etiology-wise response rate, viral versus non-viral, which includes the NASH as well as alcoholic, TBC, other etiologies of liver disease, in which obviously the result with atezolizumab was maximum with Hep B-related cirrhosis, then with the non-viral etiologies, non-Hep B cirrhosis, then lastly with Hep C related. So viral also, if you divide into Hep B and Hep C, B perform better than Hep C. So,
Okay.
but as Dr. Preeti has rightly pointed out, it was a post-hoc analysis. There were many confounders. It is not head-to-head randomization wise. So Sorafenib and this group, they were not comparable in those two groups. So still, as per the recommendation, etiology is not as a criteria to decide the systemic therapy, whether TKI is lenvatinib or atezolizumab. Etiology is not a
Okay.
consideration as of now.
So absolutely, I agree with you, both of you. Conclusion is, as of now, etiology does not decide your treatment. The treatment as of now is category 1 recommendation. Systemic therapy, you should offer atezo plus Bevacizumab if a patient is not does not have any contraindication of atezo or Bevacizumab. Secondly, what we were discussing about the etiology part, these are all retrospective studies. Most of them are retrospective studies. They have suggested that probably the combination of atezo and Bevacizumab is more effective in viral hepatitis related HCC, and NASH related HCC. You should offer lenvatinib to these patients, but these are all retrospective data. There are no prospective trials. And as Dr. Lalit has rightly said, there are no head-on data of atezo plus Bevacizumab versus lenvatinib in first-line setting. We would like to have that data so that we can exactly know what type of patient should be offered atezo plus Bevacizumab. As of now, category 1, IMBRAVE 150 has led to the approval of atezo plus Bevacizumab as category 1 recommendation. So this patient was given atezo plus Bevacizumab. He is currently, he has taken total 16 cycles in remission now and responding very well. This is on and off hypertension are there, side effects, occasional fatigue and weakness, that is all associated with atezo-bev combination. So as we have already discussed, etiology influences your treatment decisions. As of now, the answer is no. But yes, we would like to have randomized trials, prospective, which would take into consideration NASH versus hepatitis associated HCC, and also in hepatitis, as Dr. Karan has specifically pointed out, Hep B versus Hep C, what are the treatment, how does that influence our treatment decision? The clinical evidence to support etiology plays a role in treatment decision. There are only retrospective studies. No prospective clinical trials are yet to provide strong clinical evidence. So this patient, was there any, as we have already discussed, this patient should have been offered transplant. That would have been the best
Sir,
treatment
kindly
for this
conclude
patient.
your session.
Yes,
2 to 3
2
minutes.
minutes. 2 minutes. Yes, 2 more minutes. Okay, so suppose this patient has extrahepatic spread or a major vessel involvement. Would you have offered a different treatment modality rather than going for atezo plus Bevacizumab? Dr. Lalit, Dr. Manoj, Dr. Preeti?
No,
If
I
there was
think
an extrahepatic spread.
I would have gone ahead with the same.
Yeah,
Okay, Dr. Preeti,
probably
Dr. Manoj, sir?
even
So that
the
the local treatment would have the part of local treatment if there is an extra liver involvement, extra hepatic involvement, or there is a major vessel invasion, then the local treatment of taste would have been would not be there, and the systemic treatment will remain the same.
Yeah, a patient presented to you first time and he has extrahepatic spread. So will you
So
still offer atezo plus Bevacizumab?
yes, systemic treatment will remain
I think
similar.
systemic
Yeah.
spread per se does not have any contraindication. Even there are no probably subset analysis in the IMBRAVE 150 also. The only thing I would look
Actually,
for the like extensive disease where if it goes beyond the liver, then patient's performance goes down.
okay.
So in that
basically,
situation, we'll have to be very careful. If unless and until there are contraindication to the drugs, I would like to use the same treatment.
Right.
Even for the
So Even extrahepatic spread and microvascular invasion, there was a small analysis that was done of the IMBRAVE 150, and it has suggested that even if the patient has extrahepatic spread or a microvascular invasion, the combination of Bevacizumab and Atezo was far superior than sorafenib, even in the subset analysis of these patients. So irrespective of the extrahepatic spread or microvascular invasion, our treatment remains the same. Our treatment of choice should be Atezo plus Bevacizumab. And so we all know the combination of Itizo plus Bevacizumab. The Bevacizumab has anti-VEGF properties, which has immunomodulatory effects, changes the microenvironment of the tumor, and that causes increased effectiveness of atezolizumab. So IMBRAVE 150 trial, we all know this was a landmark study that has it has also included high-risk patients, as we said, the main portal vein invasion, and more than 50% of the tumor was involved, bile duct invasion. So these patients also, they did very well when Atezo-Bevacizumab was compared with sorafenib. This is the data. Median OS was 13.5 months versus 6.1 months in those patients who had macrovascular invasion as well as extrahepatic spread. So this was what I wanted to highlight. Those patients who have a high risk of, who are under high risk category, they also should be offered Atezo-Bev as compared to sorafenib. As we have already discussed, lenvatinib versus Atezo-Bev, we need prospective trials to exactly know and whether etiology plays a role or not. As of now, no, but yes, we are very interested in prospective trials. They can come up with a good data so that at least we know how to manage our patients. This is the updated OS, 19 months versus 13 months in the IMBRAVE 150 trial. Median OS significantly improved with Atezo-Bev combination. So I think, and the bleeding rates were also not significant, and as compared to both the cohorts. Bevacizumab led to more grade 3-4 bleeding. That was a hypothesis that was considered. Probably it might lead to more bleeding events, but no, it was not that. So the bleeding, any grade bleeding was 2.4 versus 1.9 in the both the arms. So this is what I conclude. I'm so sorry I had to rapidly go through that. There was a lot of glitches in between, but I'm glad I could point out few important points about the hepatocellular carcinoma management. And we all now agree that probably Atezo plus Bevacizumab is the treatment of choice for at least child patients for hepatocellular carcinoma, metastatic or unresectable. Yeah,
Thank you, Dr. Ankit. It was a wonderful moderation.
Thank you, sir. Thank you, sir. I thank my panelists. Thanks a lot. Thank you, Dr. Karan, also for giving us brief review about your initial managements. We are very that area is very untouched for us, especially for medical oncologists. Thank you.
Thank you. Good night.
Thank you, Dr. Ankit, for
Thank you,
nice
sir. Thank you.
moderation, and thanks, Dr. Karan, Dr. Lalit, Dr. Manoj, and Dr. Preeti Agrawal. All the insight which we could get through you is very important for us for day-to-day life management, because SCC is still an uncommon disease, and mostly the patient comes in the incurable stage or whatever in advanced stage. So the insights are very important. So thank you once again, Dr. Ankit. And now we would move on to the next session. Next session is sponsored by AstraZeneca. Dr. Samir has joined, right? Okay,
Yes,
so
sir.
yeah, I could see that. So
Yeah, I am. Yes.
yeah,
Good
Doctor,
evening.
welcome, Dr. Samir.
Hi. Yeah.
So this is sponsored by AstraZeneca, and the topic for discussion which Dr. Samir will present is durvalumab plus Gemcis is the new standard for care in the first line advanced biliary tract cancer. So, sir, it's over to you. And Dr. Samir Khatri is a Senior Director and Medical Oncologist in the Max Super Specialty Hospital, Parparganj. So, sir, over to you, sir.
Okay. Thank you, Dr. Singh. Thank you for your kind words and inviting me for today's talk. So, moving from one deadly disease to another one, gallbladder cancer.
Exactly.
So, I will share my screen. Just a minute. My slides are visible?
Yes, sir.
Yeah. So, as I said, moving from one to another deadly disease. So, I will be talking about gallbladder cancer and what are the latest data. And we'll be talking about this durvalumab plus Gemcis. And is it a new standard of care as a first line in advanced biliary tract cancers? So, India, as we all know, has a very high burden of gallbladder cancer. So, in India especially, the gallstones, the history of gallstones, and it is there, but along the Ganges River, so especially North India only, so incidence is very high as compared to the Western population. So these are few of the statistics, and as far as the National Cancer Registry is concerned, it reported nearly 32,000 new cases, and the cruise incidence of gallbladder and biliary tract cancers in female was highest in the states of Assam and Delhi. And these 90% of biliary tract cancer, unfortunately, are diagnosed in a very advanced and unresectable, incurable stage. So patient treated with this current standard of care, which we all know is the gemcitabine and cisplatin, which we are using for last 15 years or so. And but the median overall survival is remarkably low, less than 1 year, and hardly any 5-year survival is there. And as we can see from the graph, that there has been an increase in the trend for the incidence of biliary tract cancer in both males and female over the past few years. So what are the current management options available? Current, as I will say, the last 15, 20 years, we are using this drug, and gemcitabine and cisplatin. This is 2022 NCCN guidelines, which had gemcitabine cisplatin as category 1. And since 2010, it is standard of care. And it all started with this ABC-02 study, which established the role of gemcitabine and cisplatin, and it remained as a standard of care. So if we see 11.7 months versus 8.1 months was the median OS, and median PFS was again much better, 8 months versus 5 months. And another very important combination is the gemcitabine and oxaliplatin. And again, this trial, which compared gemcis with gemox, and it established that though hardly any difference was there between them, but the overall response rate was slightly better with gemox. But I personally start with gemcitabine cisplatin, and then in the second line, I use the oxaliplatin. So I save oxaliplatin for the second line. So there was big hue and cry about the maintenance therapy, the maintenance gemcitabine in advanced cancer of gallbladder. But it only showed there was no PFS advantage and no overall survival advantage with this continuing the gemcitabine beyond 6 to 8 cycles. So the treatment of advanced gallbladder cancer, as far as the real world is concerned, so this is few of the data from the real world, which again established that in this study, the OS in this study appeared to be lower than the published literature, but a group of patients, a subgroup of patients, they had a prolonged survival with continuing the chemotherapy. They continued chemotherapy for a long time. But still, it is a very debatable the role of maintenance gemcitabine. Now coming on to this topic, the immunotherapy, as far as the first line is concerned, and it started with this phase 3 trial. We all know about this, the double-blind placebo-controlled study of durvalumab in combination with gemcitabine and cisplatin in patient with advanced biliary tract cancer, the TOPAZ-1 study. These were locally advanced or metastatic BTC. Mainly BTC consists of the intra and extrahepatic cholangiocarcinoma and gallbladder cancer. And even the recurrent disease was also taken, those who had relapsed after 6 months of surgery or adjuvant treatment. 1:1 randomization of 685 patients was there, and durvalumab and gemcis versus gemcis and placebo. And those patients who did not progress, they move on to the maintenance therapy after 6 to 8 cycles. The main objective was the overall survival, and secondary objective is the PFS, overall response rate, duration of response, efficacy according to PDL1, and the safety. As far as the patient demography and the baseline characteristics were concerned, so they were well matched. They were all, but if we see the intra and extrahepatic, the intrahepatic cholangiocarcinoma were about 55-56%, and gallbladder cancer in this study were 1/4 of the patient were the gallbladder cancer. And locally advanced were 11%, and metastatic were about 80 to 85%. So according to MSI high was in hardly any patient and missing in about 50% and stable in about 50% of the patient. And look at the PDL1. So about this was done by the TAP, this and tumor area positivity, and this more than 1% was in 57, about 57 and 60%, and less than 1% was in about 30%. And in this both the arm, if we see the ongoing treatment after the discontinuation of chemotherapy, 20% are still were on the ongoing treatment versus just 5.8 with the placebo and gemcitabine. So now look at the Kaplan-Meier curve. And it's established that Imfinzi, that durvalumab, is the first and only approved IO in combination which has shown a 2-year sustained and durable overall survival benefit. So if you see that 2 years, the OS is 23.6 versus 11.5 with the hazard ratio of 0.6, and the median OS was 12.9 and 11. So if we see the subgroup analysis, basically it benefited, this combination benefited in all the subgroup, but though the quantum of benefit, if you see in non-Asian was not that much, and rest of the world was also not that much. Locally advanced did much better, and irrespective of PDL1, it was better. And in gallbladder cancer, in this study, the benefit was there, but not that much. So, but in Finzi with the gemcitabine and cisplatin, it also demonstrated a statistically significant improved PFS against the gemcis alone. Again, the curves have separated well, and 12 years, the PFS was 16 versus 6.6. Again, the PFS benefit was across all the subgroups, and again, non-Asian did not do very well as compared to the Asian, and gallbladder cancer was not as much as the. So this is the overall response rate, and it resulted that 1 in 4 patients, they remained in response even beyond 1 year of treatment. And again, this is showing the duration of response. The median duration of response was 6.4 versus 6.2, and the median time to response, it was just 1.6 months versus 2.7. So, and very important thing from this study was that those patients who responded to the therapy, they continued to respond and beyond the 2 years. So there was a clear and sustained separation, as we can see, among those patients who responded versus who did not respond. And this is practically flat line now. So this is very important. And another very important aspect is the tolerance aspect. So it was very well tolerated and did not add to any additional toxicity profile. So these are the important side effects, and we all know about these side effects. The neutrophil C, hardly any grade 3 or more side effects were there. Mostly well managed grade 1 or 2 side effects were there. Hardly any pneumonitis and hypothyroid dermatitis we often see with the use of immunotherapy. So another very important aspect is the effect of mutation, how it impacted the survival in this. So as we are now doing NGS in most of our patients, or even in BTC also, and we are getting results, many genetic mutational abnormalities and genomic alteration landscape, we are now gaining more and more about this. And important is the ERB2, DACA, BRAF, and all we are seeing. Especially in gallbladder cancer, we are seeing many patients, they have HER2 even positivity. TP53 is another thing which is affecting in BTC. So again, this genomic alteration, as far as the primary tumor is concerned, so it has a difference as far as the intrahepatic, extrahepatic, or gallbladder cancer is concerned. And as we can see in gallbladder, the more this HER2 positivity is there more, and as compared to the others. So this may have impacted the overall survival, this genomic alteration. And as we can see, those patients who are RB2 positive, there it was not very effective. Now coming on to the real world evidence, and these are two studies, one from Italy and one from India. So this is again the patient demography and disease characteristic were similar, and this was the 145 patients were there, was similar to the TOPAZ study. And if we again see intrahepatic and extrahepatic, they were more common, but gallbladder cancer were very less in this study also. But look at the overall survival and median PFS. It was 12.9 months, the overall survival, and median PFS was 8.9 months. Again, similar to the TOPAZ study. And adding durvalumab seems to improve the overall response rates also. The objective response rate of 34.5 months and stable disease in 53.1. So partial response was 29.6 and complete in about 5% of the patients. Again, the safety and tolerability, it was well tolerated in this study also. And now coming on to this Indian study. So again, a real world study of durvalumab and chemotherapy in Indian patient with advanced BTC. And these were the centers participating in this. So about 75% patients, 75 patients were included from between Feb 2022 to January 2023. Median age was 60 years. And if you see male-female ratio is there. And here importantly, gallbladder cancer was more common and as compared to interhepatic and extrahepatic cholangiocarcinoma. So if we see the treatment characteristic, the median follow-up was 4.9 cycles of durvalumab was median cycles were 4, and chemotherapy cycles were median was 5, and patient progress was 42, deaths were in 26. So disease progression was 76% disease progression leading on to the death, and treatment related was only 10%. So patients who were alive on treatment were 31. So again, if we see gallbladder cancer, the overall survival was 8.4 versus the cholangiocarcinoma, which had a better overall survival of 14.2. So, and if we talk about median overall survival of all the patients, then it was 9.7 months. So importantly, the gallbladder cancers, they fared poorly as compared to the cholangiocarcinoma. And PFS of gallbladder cancer was 5.2 months versus cholangiocarcinoma, it was 6.2, so more or less the same. And median PFS was 6.1. So PFS benefit was seen across all the subgroups, be it gallbladder or cholangiocarcinoma. Again, the safety and toxicity were well tolerated. We are using immunotherapies for so long now, and we are well versed with all these side effects like hyperthyroidism, pneumonitis, skin toxicity, hepatitis fever, but no big toxicity. So from these real world experiences, it is the first two reported real world evidence of durvalumab and chemotherapy from India and Italy. There was a significantly higher proportions of gallbladder malignancy and a patient with PS2 or higher in Indian population. The PFS, overall survival, and the response rate were comparable to the TOPAZ 1 study, and the overall survival was slightly lower in Indian study, though there was a greater number of gallbladder cancer. So maybe this is the reason why the overall survival was slightly lower in that. And potentially there is a lower use of second line targeted therapies in Indian population. There is no safety concern and is very well tolerated. The combination of durvalumab and chemotherapy appears to be a safe and efficacious regimen in the biliary tract. So no doubt It was incorporated as a category 1 recommendation for the primary treatment of unresectable and metastatic BTC, and now it is incorporated in NCC. So I will like to conclude that this combination of Imfinzi with gemcitabine cisplatin demonstrated a statistically significant and clinically meaningful overall survival advantage as compared to both in phase 3 global clinical trial as well as the real world data. Durvalumab did not add to additional toxicity, and this Durva plus GEMS appears to be effective across all the molecular subtypes of BTC. The patients with targetable genomic alteration, they also benefit from Durva plus gemcitabine cisplatin. And now the DGCI has also approved Imfinzi 1500 milligram in combination with chemotherapy in advanced, locally advanced and metastatic BTC. So with this, I would like to thank you all for the patient listening. Thank you.
Thank you, Sabir sir, for your nice presentation.
Thank you.
Okay, thank you, sir. So now this is the last session, which for which I would invite Dr. Ankur Punia again. So he is the assistant professor in Mahatma Gandhi Medical College, Jaipur, and this session is sponsored by Mark. And the topic for discussion today in this session is the evolving trends, the evolving targeted treatment landscape in the RAS wild type metastatic colorectal cancer, first line and beyond. So, Dr. Ankur.
Yeah, so the last session of the day, I'm basically
Last
going to talk about the role of targeting RAS wild type patients in metastatic CRC.
Yeah.
So we all know that that happens in usually all the malignancies. We'll treat with the patient in the first line. Most of the patients will respond. They will have a PFS in CRC for around a year. Then almost half of the patients will only receive the second line therapy, and again only almost just 20% of patients will eventually receive. I think this number will be even lower in our setting, and very few patients actually go to third line treatment. I'll say around 10% only. So this is the real world scenario which happens in the life of a metastatic CRC patient. So now we have multiple options. How do we choose what options to take? So it all depends on multiple things. We have the age, how the performance status of the patient, any comorbidities of the patient, so we can decide what kind of therapy to give, what kind of therapy to avoid. The tumor location, which has come a big thing in the last few years, and now we are going to genomics, but still it helps us to decide in majority of patients when we are not able to do any broad genomic testing, and obviously biomarkers, as we are getting understanding more and more about the molecular pathogenesis behind CRC. We are getting more and more biomarkers as well. So we look at it, there are now CRC also shows diverse biomarkers. As we can see, the most common, yes, is obviously the RAS and the PIK3 mutation, which comprises majority of the population. Then the PIK3 is around 8%. Then we have multiple mutations, most commonly is BRAF, then we have MSI, HER2, NTRK, and others. And around a quarter of patients are actually completely wild type and are the suitable candidates for anti-EGFR therapy. So what basically defines tumor-sidedness? Tumor-sidedness is basically a surrogate. When we are not able to do molecular tests, it tells us about the molecular underlying biology of CRC. Right-sided tumors tend to have a higher stage, tends to more of MSI high tumors, more of BRAF mutation, PIK3 mutation, have the CIMP and serrated pathway, which portends a poor prognosis. There is the activation of downstream activation of MAPK cascade, and they have a high microRNA expression. So they are usually considered more of resistant disease, and they eventually don't have that much good of outcome. Left-sided tumors more like behave like chromosomal instability, have HER1 or EGFR or HER2 amplification, and most majority are dependent on epidermal growth factor signaling. So these patients are more likely to respond to a anti-therapy which is targeting this pathway. So we are going to start with the RAS wild type patients. What kind of therapy to use, whether to give chemotherapy along with the anti-EGFR or anti-VEGF. Now we have multiple studies which have shown, now these are the two main meta-analysis by Khattak and by Lee, which clearly shows that all the benefit in PFS and OS favors when we give anti-EGFR upfront followed by VEGF inhibitors rather than giving VEGF inhibitor followed by second line EGFR. So the best choice for the patient and best chances of getting a response and a long-term outcome for a patient with a RAS wild type CRC is to give anti-EGFR first, followed by VEGF, rather than the reverse. So now coming to sidedness, so we know that now in left-sided tumor, we prefer a choice of anti-EGFR, which has been the guidelines for almost 4 to 5 years. Now we are understanding more and more molecular basis of this, so it might change in the coming years, but still majority of patients, we will go by whether left or right-sided tumor. So this was based on this analysis of 6 trials in which basically they divided the patients in left versus right, and it was clearly seen that patient with left-sided tumors had a significantly better responses with anti-EGFR therapy and was not so that much in the right-sided tumors of all these 6 pivotal trials. Similarly, the same thing happened in the meta-analysis. 2 meta-analysis showed the same thing, basically, that in left-sided tumors, the combination of an anti-EGFR therapy with a doublet was better than giving an anti-VEGF therapy. So based on all this, it has now sort of become a standard in the left-sided tumor that we use anti-EGFR therapy like cetuximab. So same we can see in the pivotal trials of CALGB and FIRE of cetuximab, that for patient that had an OS benefit of adding cetuximab versus bevacizumab, it was around 10-month difference in FIRE3 and 7 to 8 month difference in CALGB. And similarly, paradigm study for panitumumab showed more or less the same thing, that the benefit was there. And we also can see the response rates were also higher, in the tune around 10 to 15% more when we added anti-EGFR therapy, sorry. So we can see in the FIRE3 and the CALGB trial, which used cetuximab, the graph separated early, though in paradigm study with panitumumab, they started to separate almost after a 2-year difference. But eventually, all these trials showed a benefit of adding anti-EGFR therapy upfront in these patients compared to anti-VEGF therapy for left-sided tumor, basically. Now we have real-world data as well from Japan and China. Similarly, Japanese real-world data of around 80 sort of patient showed the same thing, that OS was around 56 months in the patient who used upfront EGFR therapy compared to just around 30 months in patient who used anti-VEGF therapy upfront. And a similar thing was seen in a China real-world study, which showed that a median OS was around 40 odd months in patient who used upfront cetuximab or Erbitux. So if we look how we can, channelize all these therapies, if we use cetuximab upfront followed by bevacizumab in third line, so we get sort of the maximum OS data which has been reported is around the tune of 40 months in FIRE3 CALGB, rather than using anti-VEGF and followed by anti-EGFR therapies. So the benefit was OS was seen in the tune of around 30 odd months. So yes, we have started anti-EGFR therapy. So how long to continue that and what to do in the maintenance? So ESMO guidelines tells us clearly that if we started with the bevacizumab along with the chemotherapy, then we should consider continuing in maintenance bevacizumab plus fluoropyrimidine. If we are used anti-EGFR therapy, same fluoropyrimidine plus an anti-EGFR as a maintenance. And if you use just chemotherapy, then maybe continuing irinotecan therapy or a fluoropyrimidine is an option. So this has been shown from this macro-2 study in which the patients were randomized with either to cetuximab FOLFOX 8 cycle followed by just cetuximab maintenance, or to continue cetuximab FOLFOX till progression. So we can see that there was not any difference in PFS, overall response rates, and PFS 9-month PFS rate, which is the primary endpoint. So to discontinue early the chemotherapy and just continue cetuximab showed more or less the same results. So based on this, we can stop chemotherapy after 8 to 10 cycles and just continue the patient on cetuximab alone. So this was seen as such in the patient who had a KRAS wild type or RAS wild type population. More or less the same thing was seen, that either you continue or stop chemotherapy and just continue cetuximab alone. PFS and OS was more or less similar, and there was no difference between the survival of these patients. So we can stop the chemotherapy and give the sort of break from holiday to the drugs to the patient, and just continue cetuximab therapy for maintenance for these patients. This was again more or less seen in this different study. Again, it was with FOLFIRI. Here it was cetuximab was given along with FOLFIRI till progression, or after 8 cycles of chemotherapy and cetuximab, there was cetuximab monotherapy. So they divided based on whether the patient had early tumor shrinkage or not. Yes, patient who has early tumor shrinkage showed a good response, but overall, again, you can see there was not that much of a major difference. And in fact, the OS was slightly better in these patients in whom chemotherapy was stopped and cetuximab was just continued. PFS was more or less same and OS was slightly better. So not that much statistically significant, but again, it shows that in this MS study, you can stop chemotherapy and continue to give just anti-EGFR therapy as maintenance post 8 cycles of chemotherapy. So this is a meta-analysis. Basically, we shows the same thing, what kind of maintenance to use, and it clearly shows that in based on all these phase 2, phase 3 studies that giving a combination of fluoropyrimidine and anti-EGFR therapy is should be considered like a standard maintenance options for these patients post chemotherapy and a EGFR inhibitor, especially in the left-sided tumors. So it more or less I have told the same thing, that we use this based on the understanding that we define how whether to understand the underlying anti-EGFR resistance is there or not. And an intermittent anti-EGFR based strategy may delay also the onset of acquired resistance mechanism and can be of particular interest in some patients. So though the patients with primary resistance, which are more or less seen in the right-sided tumors, may not derive the optimal benefit from these intermittent or chemotherapy-free strategies after an induction therapy. So that's why we more or less use a continuation therapy in the left-sided tumors. So what to do for these patients when they have received upfront EGFR therapy, chemotherapy, then given either VEGF inhibitor in the second line? What to do for these patients? The patient number not that much be high, but there are few patients who will present to us with a very good performance status. And what to do for these patients in the third line? We have few options, toxic options. We don't know how much most of the patients are not able to tolerate, like regorafenib or trifluridine tepracil. So this is based on there is a Centenny hypothesis that explains the rationale why we can re-challenge the patient in the third line. So when we use an anti-EGFR therapy upfront, so patient develops to start developing clone, and the frequency of the allele frequency of those resistant clones starts to increase. The patient acquires secondary RAS mutations. And as we stop that anti-EGFR therapy in the second line, those clones starts to decrease, and that frequency really VF might decrease as the patient receives second line treatment. So in third line, if we can do a repeat genetic testing or a liquid analysis of this ctDNA, and we can see that KRAS mutation is not there, then we can challenge these patients with again cetuximab single agent in third line setting. It has been seen that patients who had a good response earlier are more likely to again respond to anti-EGFR rather than patient who responded for a short time in the earlier setting. They are less likely to respond to the same drug in the third line setting. So the cricket trial, basically a small study which took this concept of re-challenging the patients with cetuximab in the third line setting along with irinotecan, and it showed a pretty good response rates of around 20%. Half of the patient responded, and 50% of the patient had a disease control rate. So yes, a good number of patients might again respond to cetuximab in the third line setting. As I told you, by doing a RAS ctDNA testing, you can clearly see that patients who are wild type had a better PFS as well as OS compared to patient who had a mutated ctDNA was found in the blood. The PFS was also not that much great, as well as the overall survival was improved. So yes, for an option selected group of patients with a good performance status who are eligible for a third line therapy, if we are able to do a ctDNA testing, we might be able to re-challenge a good number of patients again with cetuximab in the third line setting. So these are multiple, phase 2 and smaller studies which more or less show the same thing, that patients were re-challenged, and we can see a good number of response rates. They're going to 50, 60 to up to 80, 90%. So yes, it's a good option to re-challenge these patients again who has responded in the first line setting. For patient who has not responded in the first line setting with anti-EGFR is unlikely to again respond to just anti-EGFR therapy in the third line. So this is an indirect analysis of basically comparing in the third line setting anti-EGFR therapy compared to either regorafenib or tepracil, as I already told you. So again, it's not a direct comparison. We don't have a head-to-head study. But if you look at this indirect comparison, it shows that PFS was better when given anti-EGFR therapy, as well as the OS was improved. Even the response rate was very, very high. more so in the left-sided tumors, but there was not any major difference in the right-sided tumor. So yes, based on this, again, it's boosts our confidence to whether we can use cetuximab again for these patients, because I think my personal opinion is much better and easier to tolerate cetuximab than to tolerate regorafenib or tipracil and all these drugs in third line setting for majority of our patients. So based on all this, now it is a standard recommendation for EC. We don't have a randomized study. So it tells us that yes, patients can be rechallenged. RAS wild type patient, particularly left-sided, can be rechallenged again with the anti-EGFR monoclonal antibody post progression in third line setting patient who has responded particularly in the upfront setting, and more so in a patient if you are able to do a ctDNA are still RAS wild type. So now what about we have discussed all this about the left-sided tumors and all these things. So what about the right-sided tumors? So that meta-analysis showed that more or less that OS was not different in the patients who were used EGFR or VEGF therapy in the right-sided tumors. So based on that, VEGF therapy is ideally recommended because OS and all were slightly better in these patients if we used anti-VEGF therapy for these patients in the right-sided tumors. But there is another thing. There are certain patients who are candidate for cytoreduction of who can be considered candidate for eventual surgery. For these patients, we have evidence that using EGFR therapy shows a higher response rates compared to bevacizumab therapy. So for these patients, yes, this might be an option to make these patients possible candidates for surgery. So for these patients, giving anti-EGFR therapy irrespective of sidedness might be a good choice to make these patients, make them patients more potentially resectable, and it might be some of these patients might be eventually curable. As we can see, more or less in the meta-analysis showed the same thing, that response rates and resection rates were increased, although there was not that much difference in PFS or OS. So yes, some candidates, even in right side, might be a candidate for, challenging with anti-EGFR therapy. As we can see, the same thing, the early tumor shrinkage, which I earlier told, is more with when used cetuximab is used compared to bevacizumab, even in right side tumor, which is shown in this Fire 3 trial analysis, though not that number of patients, around 40, 50 patients, but still it shows that responses are more with anti-EGFR, but not that much sustained. So good for a short-term response for these patients. So to conclude, now we are moving more and more to personalized treatment in CRC based on multiple molecular analysis. We are using left and right, which might eventually be replaced by further molecular analysis. For left side tumors, yes, standard is to give cetuximab chemotherapy. For certain right-sided patients who are potentially resectable or can be considered resectable, we can give cetuximab to increase the response rates. The Santini hypothesis, which gives us the confidence of challenge, which based on the cricket study, that yes, we can re-challenge patients who has received EGFR therapy in the first line to again re-challenge in the third line settings. So based on all this, now anti-EGFR agents are recommended for all the patients who are RAS wild type, and eventually more and more as with the paradigm study molecular analysis, we have seen that molecular analysis trumps the sidedness. We will get more and more data and further define which patients will definitely benefit more from this anti-EGFR therapy. Thank you.
Thank you, Dr. Ankur, for your elaborative talk. So this was the last session, and now we will depart. And thank you very much, the Team Horizon, for your technical support, especially Gitika and Yashika. And our scientific partners were AstraZeneca, Merck, Roche, Fresenius Kabi, Zydus, Reddy's, Dr. Reddy's, Cipla, BDR, Natco, Lupin, Stans, Novartis, and Vitalis. So thank you all for participating in our conference. And the Roche and the AstraZeneca, I guess I have not forgotten them, and Cipla also. So thank you very much. And tomorrow is the last day of this update meeting, and we'll meet at around 7 o'clock, sharp at 7 o'clock. So thank you very much and good night.
Thank you, Asim sir, for the closing remarks, and thank you all the faculty and delegates. And good night. And definitely we will join by tomorrow evening at 7 at sharp 7